this week is the birthday of one of our students, Ricardo Corpuz. So as a first song, we're going to play a real birthday song that rocks. And Shakira is going to come over from Colombia to the Philippines to dance for him as well. Happy birthday, Rick.
Happy birthday to you. Happy birthday just for you. Happy birthday to you. Happy birthday, happy birthday. Just a day, just another year, good in our eyes, you are the best. Gonna love you above the rest. Oh, all the times I was not on you, your happiness always comes away. Waiting to love you, waiting to celebrate your day. But that won't change what we already know. You're such a great friend, and in our hearts your love will grow. Let us be a feeling good. In times of trouble we will hold your hand. You're such a great friend, and we will love you till the end.
Good morning, everybody, and happy birthday to you all. Even if today is not exactly your birthday, today is almost exactly the birthday of Rick Corpuz, and that's who the song was dedicated to. Today is session number 17 of Global Online Medical School Pathology, and today is also Thursday, November 1st. Last night is what we called in the United States Halloween, so all the little goblins came by and they robbed me of all of my candy. It's also today what we call in our religious community, Catholic Church, All Saints Day. This is the day we honor all of our saints. Today we'll be discussing the third and final part of the discussion on infectious diseases. And we'll be doing that in the first hour. We should probably finish it up because we don't have much left. And then we'll take a nice break with music that was selected by both some students, our top song sending students, as well as myself. And then we're going to have a nice, fun lab. It seems like we've been neglecting lab. There are certain things in lab that are just really fun for me, and we're going to do those today. And there are certain chapters that you really can't put a nice lab into, but we try to do a little bit of lab for every chapter. Okay, we might as well do our test now, and let's start it. the first question on your exam, sharpen up your pencils, is did you hear the song? And do you hear me? And we're seeing yes, 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 yes. Okay, second question is, who do you see on your screen? I bet most of you even recognize her too. Yeah, that's Shakira. She is one of the finest dancers and singers in the world. One of my favorites. When I was a younger guy, I used to always wonder why these old guys would always get so excited by babes like this. I couldn't understand. I thought it was kind of stupid. And now I am an old guy, and I do get excited about Shakira. So now I understand better. Just took a little time to understand. That's Shakira, and she will be arriving at the house today of Rick Corp, who's in the Philippines, and jumping out of the cake and singing happy birthday and giving him a big kiss as well. Okay. Also, I'm not going to make a big announcement now, but I'm going to make a very big announcement right after the break. So after we listen to our songs, we're going to have a nice, big, and nice announcement too. Hopefully, it's going to make this course a million times better. But it's going to involve some risk and some adjustments. So stay tuned after the break for a big, big, big announcement. Okay, we might as well get going then. I believe where we left off in the last discussion on infectious diseases was generally general classifications of bacterial diseases that can be stained with the Gram stain, whether they were bacilli or whether they were cocci. And we generally got a nice general idea of the Gram staining properties and the general things which the diseases are without going into all the details like you do in microbiology. So remembering that there are other classes of bacteria also, for example, bacteria that do not stain with Gram stain very well, but stain with an acid-fast stain. The next group of bacteria and bacterial diseases are the acid-fast bacteria, generally also called mycobacteria. And of course, in this family of acid-fast bacteria, stained best by what we call the acid-fast stain, and some people call it the Zeal-Nielsen stain, is tuberculosis. You know, one of the number one killers formerly. I don't think it's at the top of the list anymore, but it's certainly at the top of the list now in terms of infectious, opportunistic infections with the AIDS epidemic that's going on. So TB is an acid-fast bacillus. There are a whole family of what we call atypical mycobacteria. In other words, TB-like mycobacteria, which are not tuberculosis. They're in the family of what we call atypical mycobacteria. And of course, the most important of which, one that is running rampant also in the AIDS epidemic, is something called Mycobacterium avium complex, or simply MAC. We have to remember a disease you may not see, but it's also a classical acid-fast mycobacterial stain, chiefly of the skin and nerves of the skin, also stained by the Zeal-Nielsen or acid-fast stain as leprosy. So here we go. I think you kind of recognize these instantly. The general rule with granulomas is when you see a granuloma, which is classical with these multinucleated giant cells like you see here, maybe a little cuff of lymphocytes on the outside usually. Sometimes even, especially in the older granulomas, they may start to fibrose or produce collagen, and sometimes that collagen goes throughout the entire length of the granuloma, in which case we call it a hyalinized or sclerotic or fibrosed granuloma, but the best term is hyalinized granuloma, which means it's all hyalinized, is tuberculosis. The general rule is if these granulomas are necrotic, in other words, you don't make out cellular detail, but it's a granular crud rather than well-formed fibroblasts or collagen, necrotic granulomas are regarded as tuberculosis until proven otherwise. But if I made a list of all the granulomas that have been shown to have some necrosis. It's probably about 100 other things. In fact, any granuloma technically can become necrotic in the center if it's big enough, or let's say outgrows its blood supply easily, and these are all the classical features. So a granuloma that is necrotic on the inside, you can still recognize these multinucleated or Langerhans giant cells scattered about. But a granuloma does not need multinucleated giant cells to be a granuloma. All you basically have to have is a cluster of macrophages with or without necrosis, and then lymphocytes classically on the periphery, and sometimes fibroblasts surrounding this. Now, if you do the acid-fast stain or the Zeal-Nielsen, and it's in a granuloma that is just loaded with acid-fast bacteria, you may see something like this. Every one of these little balls here is probably a cluster of 50 or 60 or 100 acid-fast bacteria. Sometimes you could see an individual one, like you can see over here, and maybe you could get a feel for about 10 or 15 of them in this group. They are true bacilli. You can say they're not cocci. They don't stain very well with the gram stain, and that's why they're called acid-fast. Now here is another closer view of an acid-fast bacillus. It's MAC. There is nothing in the morphology of the acid-fast bacilli which identifies it as being Mycobacterium tuberculosis versus the other atypical mycobacteria. So all you can say is that these are acid-fast rods, acid-fast bacilli. And then you would have to rely on culture or other immune tests, as well as the patient's history, of course, to support your diagnosis of which specific mycobacteria it is. Now, if you think that looking at staining a granuloma with the acid-fast stain, you're going to see all these things, the reality is that very often, if you wonder why pathologists look into microscopes for hours, very often you may take a field like this, for example, and stain it with your acid-fast stain. And you may have to go on high power, perhaps even higher power than you see here. And if you're lucky, you may find one or two. And the general rule is it might take you 10 or 20 minutes to find one classical acid-fast bacilli. And as soon as you do, then you see like 3 or 4 more, and you go, oh my God, I finally found them. So that's the general rule for acid-fast bacilli bacteria. Okay, what about the bacteria that don't stain with acid-fast techniques? They don't stain with the gram stain. But morphologically, they are spiral in configuration. Well, very appropriately named, these are the spirochetes. And of course, the classical, all-time classical spirochetal disease is syphilis, genus name Treponema, species name Pallidum. Okay, and even though they don't stain very nicely with anything, if you use a microscopic technique called a dark field, you may see that these things can stand out very nicely. This is not a stain. This is the way light is hitting them in a dark field. Now, there are other tropical spirochetal diseases which we're not going to go into, and there are some local diseases. For example, Lyme disease. I had Lyme disease a couple of years ago. I learned that it's the #1 concern vector disease in the United States right now. Might have started out or been originally elucidated in a province of Connecticut called Lyme, now all over the world. And I was in my own state of Illinois, near the Wisconsin border, doing what I usually do, and that's going through the jungles, going through the wilderness. Notice a couple days later, a tick. Okay, it was in a place where I normally wouldn't have ever suspected it. It was on a weird part of my thigh that really you can't see or even feel very nicely. Pulled out the tick. A few days later, I got really high fevers, and I thought, well, maybe I'm coming down with a cold. But most of the fevers, due to the viral prodromes, last, maybe less than a day, sometimes just a few hours. This one stayed for a couple days, and I thought, oh shit, I got Lyme disease. So, luckily enough, it was diagnosed early and treated early. And even though Lyme disease feels like hell in the acute stages with fevers and muscle aches and joints pain, it generally is very self-limited, okay, and has a low mortality at all. Nobody dies from acute Lyme disease. Now, if it's not treated or diagnosed early, it goes into chronic Lyme disease. And the symptoms and effects of chronic Lyme disease are sometimes very debatable, especially the cardiac, long-term cardiac or neurological or joint manifestations. But there is a chronic Lyme disease. What it actually, the damage of what it actually does is very debatable. And another spirochetal organism, now not in the Treponema family, but in the Borrelia family, just like Lyme disease is relapsing fever. Okay, this is not something that's very common. It could be very serious, though, and by its name, you would think that it's a fever that comes and goes and comes and goes. In fact, I believe that the genus name for this particular spirochete is recurrentus, which is very appropriate because it's a recurrent fever. And that also has a vector of lice and soft-bodied ticks as well. Might as well talk a little bit about syphilis, the classical spirochetal treponemal disease. Something hopefully you may not see very much of, something we hope is generally gone with proper treatment and diagnosis, but you still see it in all phases. And of course the first phase is something that's called primary syphilis, and that's characterized by a painless chancre. Okay, you can't really call it a vesicle, but you can call it a soft, painless lesion wherever the contact was. In this case, it happened to be the tongue, but it could just as easily be the genital. This is a STD. It may have some inflammatory cells around it in the primary stage or even the secondary stage. And those inflammatory cells, for some reason, are usually plasma cells. They're not so much lymphocytes. They're not so much neutrophils, but a inflammatory skin lesion with a significant plasma cell infiltrate might be suspect for being secondary syphilis. Of course, primary syphilis is a painless chancre. Secondary syphilis may appear months or even for years in a variety of different inflammatory skin manifestations. The many faces of the secondary skin manifestations are just too numerous to enumerate. But like I say, generally an inflammatory skin lesion characterized by a fairly purely plasmacytic infiltrate might be suspect for a secondary syphilis. And of course, there is a tertiary syphilis now, usually many years after the disappearance or even ongoing with secondary. And these are called generally gummas. And they are very significant granulomatous type lesions. They don't look like true granulomas. They just look like big necrotic globs that are about as big as granulomas. And they can involve brain, they can involve bone. And of course, somebody that is born to a person infected with Treponema pallidum can have symptoms of congenital syphilis as well. I don't want to go to it in too many details. When I was in medical school, we probably spent a half a day on it because it was a very, very significant disease. But I think what I said now is a pretty nice summary considering, the kind of world we have today. Okay, what about the bacteria that may stain positive or negative with the gram stain, but their characteristic is that they don't need oxygen to survive? Well, these are the so-called anaerobes. And of course, if they use oxygen, if it's there, it may better be termed a facultative anaerobe. But generally, anaerobic infections are caused by anaerobic bacteria. They could be gram-positive, they could be gram-negative. There are a lot of anaerobes in our gastrointestinal tract. if you see if you culture a wound of gas gangrene, in other words, an infected abscess or an infected cellulitis or an infected organism which is releasing bubbles of air because the bacteria are creating gases, it's very likely that these are anaerobic bacteria, and very number one on the list is Clostridium. So Clostridium perfringens, other species of bacteria, are considered probably the single most major cause of a gas gangrene. Okay, what about the so-called OIBs, or if you want OIIs, because some people doubt if these are really true bacteria, because sometimes they lack the classical findings which you must have to be a bacteria. But let's mention a few of them anyway. And of course, probably at the top of the list is chlamydia. Chlamydia, a very, very, very common cause of urethritis, a very, very common cause of salpingitis. You know, a couple of generations ago, if somebody had a urethritis that was loaded with pus, or a salpingitis, fallopian tube that was loaded with pus, they would say this is gonorrhea, gonorrhea, gonorrhea. Nowadays, it's almost just as likely to be chlamydia. Another thing to remember is that worldwide, chlamydial infections can infect conjunctiva and corneas as well, to produce blindness. And this is in many, many, many people. It's one of the leading causes of blindness worldwide. Another chlamydial infection, which I'll mention briefly, is a genital infection involving genitals and usually inguinal lymph nodes, called LGV, for lymphogranuloma venereum, also a venereal disease appropriately named, also caused by a chlamydia, and usually self-limited and treatable. Now, what about these critters called the rickettsia? Or what about these critters called the mycoplasma? Well, like the chlamydia, they are obligate intracellular bacteria. They have to live in cells. You can't culture them. And rickettsia have been known to cause both Rocky Mountain spotted fever as well as typhus, both pretty serious infections. And I don't think I want to go too much into it. I might say a few words about Rocky Mountain spotted fever. I think you should know that typhus is a rickettsial disease. Rocky Mountain spotted fever is caused by a rickettsial organism. And there's probably a bunch more, but those are probably the two that are of significant worldwide importance right now. Mycoplasmas, a lot of different species, very, very commonly a cause of a community-acquired pneumonia in the United States and probably elsewhere as well. These are organisms that are also OIBs. Mycoplasmas are not, you might call them bacteria if you want, but they basically don't have a cell wall. And when we get to the chapter on pneumonias and we make a list of the commonest bacteria to cause the common community-acquired pneumonias, Mycoplasma is always near the top of the list. It might be 3 or 4 or 5, but remember, in the United States, Mycoplasma pneumonias are common. Okay, here's the chlamydial organism doing its thing. You can see this conjunctiva is inflamed, but the cornea is also very, very cloudy. So because it affects both the conjunctiva as well as the cornea, it deserves the name keratoconjunctivitis, kerato meaning cornea, and both the lid cornea as well as the scleral cornea, conjunctiva, as well as the lid conjunctiva are involved. And look at that, 100 million people worldwide. Trachoma is a Greek word for rough eye. Here is a specific tick again that is the vector of Rocky Mountain spotted fever. It is usually the tick Dermacenter andersoni. Sometimes Dermacenter variabilis is the tick that causes it. This is classically what it looks like. I guess if I showed you a bunch of ticks, you might want to know if there are some distinguishing features of this tick that differentiate it from any other tick. And I don't know if there really are. It just sort of has like a brownish and yellowish striped effect along its extremities. And you know that if it has a tick, if it is a tick, it's not just 6 legs, it's really 8. So if you turn it upside down, you'll probably see some smaller ones in front. The Rocky Mountain spotted fever, it could be a very serious disease. It's treatable with antibiotics. Here's the part is why it's called spots. It may look as spotty, as blotchy as measles, and microscopically, it causes a very significant vasculitis in the small blood vessels. So Rocky Mountain spotted fever, caused by Rickettsia rickettsii, as the genus and species name, is a vasculitis obligate intracellular bacteria. And if this is affecting significant organs like brain and kidneys, that's where you get the mortality. The Rickettsia with species name Prowazekii and typhi is the one that causes typhus. That's also appropriately named. Whoops. Let's see if I could correct that minor little typo over there. There we go. Okay, what about the fungi? Okay, we've covered and touched on fungi in one way or another. We're going to do it again from another angle. There's a lot of different ways to classify fungi in their patterns of human diseases and in their pathology, morphology. One of them, like I said before, similar to the bacteria, is whether the fungal organisms occur in the body as little balls, which we call yeasts. Although those little balls may have little smaller balls budding from them, in which case it's a budding yeast, or they may exist in the body in hyphae, which are like super large bacilli. They're actually long filamentous structures, and sometimes they have septae or little connections between the hyphae. So those might be called septate hyphae. But in reality, fungal diseases are either yeasts or molds, okay? Without a doubt, the most ubiquitous and commonest fungus infection, and even almost as a normal commensal in our bodies, is Candida. And even though there are a lot of species of Candida, Candida albicans is usually the one that is involved with significant infections. Another yeast fungal disease, especially in immunocompromised people, is cryptococcosis. It may look a lot like Candida in normal microscopy because it's just another little ball. It has some special features with the capsule, and this is a very significant concern for patients that are severely immunosuppressed, either AIDS or on high doses of immunosuppressive drugs. And of course the molds, I've mentioned a couple of species here that normally do not infect man, like Aspergillus, mucormycosis. Another name for a mucormycosis infection is zygomycosis. Even fungi, even molds that, like in bread mold, like who hasn't taken a bite of bread once and then seen at the other end a little greenish discoloration? Well, even something as harmless as that can occasionally cause an infection in somebody who is immunosuppressed. So the one basic question you ask yourself is the fungus a ball, or maybe a little ball with a bud on it? Or is the fungus a long branching rod? Another classification and another significant question you're going to ask is this fungus infecting only the skin? In other words, superficial. In other words, a dermatophyte. And the skin superficial dermatophytic fungal infections are called tinnias. Tinea is not a genus or a species of a fungus. It means superficial fungal skin infection. And depending on what word follows tinea is where that region of the skin of the body is. Or, if it's not a superficial infection, is it a deep infection? Can it infect internal organs, of which lungs are always the most likely thing to be involved by deep fungal infections, but technically almost any organ has been shown to contain these if the infection is bad enough. Just like tuberculosis. We think of tuberculosis as a pulmonary disease, but there probably has not been a single part of the body that has not been infected by tuberculosis at one time or another. Same thing with the deep fungal infections as well, whether it's histoplasmosis or blastomycosis or coccidiomycosis. So when you hear the term deep fungal infection, think of the big three: histo, blasto, coccidio. Most of the fungals, whether they're yeasts or whether they're hyphae or whether they're superficial or whether they're deep, the general pattern of inflammatory reaction of a fungal infection is granulomatous, although it doesn't have to be. Some of them could be purulent, some of them could be non-granulomatous. Another thing to remember is that even whether the fungus is superficial or deep or a ball or a string, you always have to ask yourself, is the host immunocompromised? Now, I can tell you right now, if I examined your skin and squamous mucosas, your moist squamous mucosas very carefully, I could probably find a little candida. It's all over. But why do people that are immunosuppressed or even, diabetics, why do they often run rampant with candida? It's because it's a yeast. So, the one unifying feature of just about all fungal infections, no matter what they are, is that very, very often you may be able to treat the infection, whether it's superficial or deep, but you have to ask yourself, is this patient immunocompromised? Here's the biggest one of all, Candida albicans. I think we've seen examples of it previously in this course. And what do all of the common places for Candida to infect is oral, remember we call that thrush, vaginal, cervical, esophageal. What do all of these three places have in common? Well, it's a non-keratinized, moist, stratified squamous mucosa. So as a little summary, if somebody was to ask you, what kind of tissue does Candida affect? You would say moist, non-keratinized, stratified squamous mucosa. Of course, extensive, rampant candidiasis can infect like any other fungus, just about anything. It could involve a whole esophageal wall or a whole wall of a colon. It could be a meningitis. It could be anything. And of course, you have to ask yourself, is it an immunocompromised person? It doesn't have to be an AIDS patient. It could be somebody as simple as a bad diabetic. Diabetes is not just a vascular disease or an eye disease or a kidney disease or a sugar disease. It's also an immune disease as well. Even though these are yeasts, they may look to you like they are gram-positive bacteria, except for one thing. This is not the gram stain. This is a regular H&E stain. Very often, Candida stains nice and blue, even on the H&E stain, whether it's in fungal form or whether it's in hyphal form. So Candida, as you know, is dimorphic. Now here's an individual Candida yeast over here, and there's another one with the yeast. And the three things that these arrowed yeast forms have in common is that they're sending off little buds. Well, guess what? Those little buds can actually grow into these filamentous structures called hyphae as well. So you may be looking at a scrape of a cervix or a mouth, and you may see these little filamentous structures. And the general rule is it's candida until proven otherwise. And of course, if you wanted to use a cheap, simple stain, perhaps a PAS or periiotic Schiff stain, then these little filaments would stand out very, very nicely. This happens to be a PAP stain here that you see, but if you forgot the PAP stain and did a PAS stain, these nice little filaments and even these beautiful little yeasts would be brilliantly red. We can't ignore the other major yeast fungus, Cryptococcus, and there's, as you would guess, a whole bunch of genuses of them, or species. The main infectious, devastating fungal infection of Cryptococcus to man is Cryptococcus neoformans. Cryptococcus neoformans is a major cause of meningitis and encephalitis and infections elsewhere, systemically, lung, liver, spleen, everywhere. Almost every routine spinal tap that you do, when it goes to the lab, will have a battery of tests that's done on it. And one of the things that they'll do is to put a drop of India ink onto that hopefully clear drop of spinal fluid. And the thing about Cryptococcus is if you put a drop of India ink onto the spinal fluid, the capsule that surrounds this little yeast makes it look like a big, big, big white halo. And when you see them, when you do, they look spectacular. And there's really nothing else in the spinal fluid that could do this. So it's almost like a easy slam dunk diagnosis. And it doesn't even involve a lot of fancy technology or chemistry. It's just one drop of India ink, one drop of spinal fluid on a slide. And you don't have to use any stains. You see these big white haloed single yeasts. Okay, maybe you've seen that already in the lab, I don't know. Just a word about molds again. We've seen that Candida can be hyphae as well, even though they're not true septate hyphae. The probably two most common classical, almost pure hyphal infections are things like aspergillus and mucormycosis. I think the other time I put the zygo in parentheses. Now I caught the muco in parentheses. I don't know which is more common. You could probably Google it to see which one has more hits. But classically, it's been called mucormycosis. And as you might guess, they can cause, soft tissue infections. Zygomycosis in particularly has been known to produce pretty significant deformities in the soft tissues surrounding the oral cavity. Aspergillus can infect anything. Actually, so could this. These are usually really, really bad patients. I had a person who had an Aspergillus endocarditis, and basically it seeded into just about every part of their body. And when you look at these, we have a case in lab. They just look like nice little patches of, little grass and bushes, with hyphae growing inside various organs. Okay. Tinnias. Tinnias are defined as superficial fungal infections, or dermatophytes. Even though tinnias may have something following it, like tinea barbae for the beard or tinea cruris for the groin area, if you take the three fungi, which are genuses of fungi, which are most likely to produce this, they're almost always in one of these three categories. That's why I put this in yellow. I think you should remember that if there's a superficial fungal infection, and it's called tinea something, the only superficial fungal infection which is not called tinea something is a fungal infection of the nail that has a different name. But if you take it to the lab, if you take it to the pathologist, if you examine it, it's going to be either epidermophyton, microsporum, or trichophyton. This is not necessarily in the order of likelihood. I think maybe trichophyton may be a little more popular than these other two genera or genuses, but it's going to be one of these three. Now, the tinea of the scalp or of the head is very appropriately named tinea capitis. Okay? That's not the name of an organism, that's the name of the dermatophyte. Okay? It frequently grows in a ring-like fashion. That's why it's also called ringworm. So a lot of the teneas, whether they're of the body or whether of the scalp, they're often called ringworm. And don't ever, ever, ever think that there's a worm involved. Most people, when they hear, oh, the person has ringworm, they think, oh my God, there's some little worm crawling around his skin. It's all fungal, folks. Ringworm is not worm. Ringworm is fungus. Here's a guy's beard. Okay? Barbae is the root word for beard. So a dermatophytic infection involving the beard is appropriately called tinea barbae. And besides treating this with the usual topical anti-dermatophyte things, one of the treatments for this disease is also to let the beard grow. The more this beard grows out, the less that infection will have a chance to do its damage. And that's why, when I was a captain in the Army Reserve, a lot of the soldiers came up to me and they wanted to give them a note saying that they had tinea barbae because they wanted to grow a beard and the Army wouldn't let them grow a beard. So the only way somebody in the armed services could have a beard is if a doctor said, you have tinea barbae. Here is a superficial fungal infection. It's one of those three genera. Also growing in the body now, so this is tinea corporis, happens to be on an extremity of the body, also called ringworm of the body. Just like ringworm of the scalp, it's going to wind up being one of these three genuses here. And once again, I know as a knee-jerk reflex, when you hear that for the first time, you're going to think worm. Okay, what about tinea cruris? Okay, cruris refers to the groin area, crux. Cruris is the genitive case in Latin. So, fungal infection of the groin, also called jock itch, by the way. And, and if you want to call a disease by its common street name, by all means do. I can remember working in a clinic, and I said the guy has jock itch, and somebody said, oh, you should be more professional and call it tinea cruris. I said, but nobody would understand me. Everybody knows that's jock itch. So anyway, once again, it's a little bit, might be a little bit corroded or ulcerated there, irritated. You can see there's a little thickening of the skin. It's not really growing like a ringworm in the other areas. So it's more likely to just be called jock itch or tinea cruris rather than ringworm of the groin. And here's the most common one of all, tinea pedis, athlete's foot. Usually occurs in the interspace. The fourth, the last interspace or the most lateral interspace or the one between, let's say, the fourth and the fifth toe is the most common place, but it could occur anywhere. And once again, it has that sort of a plaque-like look to it. I've always wondered why this was the most web space to grow in, and I don't know what the answer is, but when you have a diabetic person that gets a toe amputation, here, let me ask you this question. When you get a diabetic person that has a toe amputation, what is the most likely single toe to be amputated? Yeah, it's the fifth. You're absolutely right. So my guess is that by its very nature, a tinea infection will be the most rampant, where classically the blood flow is the most impaired. And that, of course, is my explanation. I think it's a logical one. Now, when you get down to the nails, it's no longer called, tinea of the nail. It has the funny name, onychomycosis, but that just means tinea of the nails. And generally, I used to see 1 million of these things. They're basically thick nails. They're very easily separated from the nail bed. And basically the treatment for these is to be removed, especially, if it's the big toenail. And then sometimes they would send the toenails to us, and we would look at them, and we would do a PAS stain, and we would identify perhaps the specific organism that was causing it, or maybe you would take it for a culture and to see whether it was either epidermophyton, microsporum, or trichophyton. Okay, let's say a few words about the deep fungi. I called them significant fungi, but I think a better word would be systemic fungi, because generally the dermatophytes do not go systemic, but these three guys do, HBC. So even though they're long words, if you just remember, hopefully for the rest of your life, that histoblasto are the systemic fungi. And furthermore, blasto and coccidio are chiefly in yeast form. So they wind up looking like little balls in the tissue. And like all fungal, it may be an overall granulomatous reaction, but with blasto and coccidio, they're little balls. And look at the coccidio balls are about twice as big as the blasto balls. So all you have to do is look at the size of those little yeasts with respect to, let's say, some of the cells around them. So if that, for example, is a lymphocyte that's 10 microns, most of these little balls look like they're about twice as wide, or 20. But if you look at some of the lymphocytes here, you'd say, oh my God, these things are about 4 or 5 times as wide. But the best way to differentiate them is to culture them. Otherwise, you're going to be wrong or look foolish. Whereas in histoplasmosis, they're not really that big. They're only about 3 microns, or half the size of a red blood cell, rather than 3 times or 6 times the size. And they usually show up as tiny little dots living inside of macrophages. And there are ways of staining these organisms. In fact, look, we have one here. This particular histoplasmosis was not from a textbook. It was not from the World Wide Web. It was a colleague that's on one of my pathology forums, and she said, look, I have a spectacular picture of histoplasmosis stained nicely. This was probably a Giemsa stain. So the same attraction of the Giemsa stain to a nucleus also shows in the specific nuclei of the histoplasmosis organisms as well. I'm not going to go into all 3 of these diseases, but I'll tell you something real quick. They all mimic tuberculosis, and as I've already said about 6 times, they all look like they're probably in immunocompromised patients. Okay, another few words about the protozoans. Let's see what time it is. Oh yeah, we got enough time to finish this now. There's just a few slides left. Protozoal diseases are quite numerous. We've already showed you material of what families infect, what types of depths of infections, and we always have malaria at the top of the list, so we are going to go into the Plasmodium life cycle. Another protozoal disease you'll probably never see, babesiosis, also has a vector. In this case, it's a deer tick. We've talked about leishmaniasis having either a soft tissue or a very deep systemic, more serious type of effect, also a protozoan. We've talked about the so-called trypanosomes. In Africa, the vector is the tsetse fly to cause sleeping sickness, generally called trypanosomiasis. Another vector, also an insect, causing a similar type picture in the Americas or the New World, primarily in Latin and South America, called Chagas disease. And we can't ignore regular old amoebic dysentery as well. And we're going to see this in lab. And the chief genus and species name for the protozoan that causes this is Entamoeba histolytica, causing amoebiasis, chiefly of the colon, but as you know, a significant, I don't know why I said as you know, because you may not know it. Most of the significant colitis due to entamoeba are probably going to wind up having liver abscesses as well. So here's a good place to start. I think on the last session we actually had a picture of this guy with the scanning electron microscope. This is the Anopheles species of mosquito, causes malaria. Might look like any other regular mosquito to you. You know what that bad boy is, going to the skin over there. And the life cycle is that if you want to start where that mosquito bites the person, what is being released into that person's bloodstream are the sporozoites, which has been released from the oocyst inside of the mosquito's body. So these sporozoites get into the human blood, they go to the liver, they develop inside of the hepatocytes, and then they are released from the hepatocytes as merozoites. Okay? These merozoites go through various phases of development then in the human's red blood cells to eventually become gametocytes. So now you have your sexual stage, don't you? You have the female gametocytes looking like little eggs, and you have the male gametocytes looking like little spiders. These are then taken back into the mosquito. They are fertilized, develop into a zygote, and eventually will release oocysts again from the sporozoite. So you have the sexual cycle, you have the asexual cycle, you have the mosquito, and you have the human. Now, the diagnosis of malaria, probably the single biggest infectious disease killer in the world, is usually obtained from looking at the patient's blood cells when the released merozoites go through various name changes and forms, eventually resulting in gametocytes. Okay? And this is generally what you might see even on a regular right stain or a standard stained blood prep. Here's a fancy false color scanning electron microscope showing some of these intermediate critters between the merozoite stage and the gametocyte stage, actually showing lysis of the red cells. So that would mean that malaria causes a hemolytic anemia as well, wouldn't it? Because it's destroying red cells before their time. So that's the life cycle. I don't know, it seems like every time I've learned about a life cycle, I seem to forget it real fast. So I'll just say that if you remember that the sporozoites are what enter the human, they go to the liver to become merozoites, and then the merozoites eventually mature on red cells to become the specific male and female gametes. That's probably the main thing you should know. And everything else is inside the mosquito as well. What about the cells themselves? Well, look, some of them look like they're little rings. You know, those are the ring forms. Some of them look like little sausages. You might call that a gametocyte. Okay, they have a variety of names, but depending on what kind of forms that you see on these cells and whether the cytoplasm of the red cell has dots or not is the way you could identify the 4 classical species of Plasmodium. Now, you may already know that Plasmodium falciparum has the highest mortality, and the other Plasmodium species can also be nasty, but the one that is so-called black water fever, in which there's so much massive hemolysis of the red cells, it results in massive hemoglobinuria, and you're peeing actually black, sometimes with renal failure. This is classically the appearance of the worst form of malaria, which is Plasmodium falciparum. Okay, and this is also the type that is frequently resistant to the anti-malarial drugs as well. So let's go through the four main features. Now, I don't expect you to remember all the names of these things like schizonts and ringforms and trophozoites. You all know it starts out as the merozoite. You all know that it ends at the gametocyte. And somewhere along the line, in most of the cases, there's going to be structures in those cells that look like they're little rings or ringforms. The distinguishing maturation features of Plasmodium falciparum, the worst one, is that the gametocytes are not hard to find and they look like little sausages. None of the other three species of malaria have common sausage-shaped falciparum. So when you're in the hematology lab and a malaria patient comes in and you stain it, and you always are looking for these features. Also notice that the red cells themselves, they don't have any dots in them either. Because if they have dots, then they're going to be one of the other two forms of malaria. So if the cell doesn't have a dot and the gametocyte is sausage shaped, you see these little cigars or pickles inside the cells, then you know that's falciparum. Well, I know we always had fun doing this, but when you think about it, usually they know what kind of malaria it is before the patient even comes into the hospital, because they know the type of malaria that was endemic for the area that they were in. But it's still fun to look at these and try to differentiate them. Here's another one called Vivax, okay? Now look, Vivax has the red dots throughout the cell. And they don't have a big cigar-shaped gametocyte. It's more oval. But these are very bright red dots. So if you see a development of ringforms and trophozoites and schizonts and gametocytes, and the cytoplasm that doesn't have these has red dots, think it's probably Plasmodium vivax. Now, I got to tell you something else. Plasmodium ovale also has Schuffner's dots. And of course, these are the regular good, stains that they use to identify malarial parasites. You could also see them on regular blood films as well. But the difference between the Schuffner's dots of ovale and the Schuffner's dots of vivax, they may not look very much different, but ovale in the ring form usually has a very thick ring, and they call these comets. So that's the key word. If a form of malaria has a comet, even if you can't see the Schuffner's dots too well, you know it's ovale. So ovale means Schuffner plus comet. Vivax means Schuffner but no comet. Falciparum means no Schuffners and a big cigar-shaped gametocyte. So what's left? The fourth one is Plasmodium malariae. And the two things about Plasmodium malariae is that the red cells are really not enlarged. They don't have a higher MCV, like the other ones do. And of course, they don't have Schuffner's dots either. So those are the diagnostic features. You know what? We spend sometimes hours trying to differentiate these things. And the fact is, if you just remember those key tips for each one, you'll be able to know it forever. Let's go to another very, very big single-celled parasitic disease, trypanosomiasis. In Africa, the bite of this tsetse fly releases trypanosomal organisms, can cause a very severe infectious disease. You could see them very, very easily in the blood. They look like little spiral things all over the place. And when you look at that fly over there, you know it doesn't look like a regular fly. You know it looks bigger and meaner, and I don't know if I can actually differentiate this in words from a regular fly, but it just looks bigger and meaner. It even looks bigger and meaner than a horsefly. Now, trypanosomiasis organisms in the South American or New World or American variety is also called trypanosomiasis, but it's more likely to be called Chagas disease. And look, the organisms look very similar also. It probably would have to take a very trained eye to differentiate a African sleeping sickness from a Chagas disease, but the Chagas disease trypanosomes are a little fatter, and usually you can see their nuclei a little bit more clearly. Otherwise, I'm not going to stick my neck out anymore. And whereas this tsetse fly is what causes the African trypanosomal disease, this critter over here is called a, oh man, I forget the name of it. Does anybody remember the name of this critter here? It's certainly not a tsetse fly, but it's another name. If somebody knows it, please make me look smart and type it in. Yeah, so they got it right. It's called Tratomedeo. It's something like that. They also call them rejuvid bugs, I guess. But this is the genus name for the bug that causes this. And look, it's totally different from the tsetse flies, isn't it? It's also on the other side of the planet, too. It's in the Western Hemisphere. These guys are in Africa, basically. Okay, let's move on. I'm not going to say much more about the worms. We've been through a couple of cycles already. I could show you those cycles again, but I don't really want to because I went over them pretty thoroughly. And I'm not going to go into a whole bunch of things on the worm parasites. You know, sometimes these little microscopic Strongyloides worms are called pinworms. Sometimes Enterobius that you see in humans is called pinworms. That just means they're very, very small. We mentioned that the tapeworms are Platyhelminthes, which means flatworm. The chief varieties are from beef and pork, but you can also get them from fish and insects as well. We noted that the pork tapeworm is also called trichinosis. We know that the schistosome worms, very, very, very common cause of bladder cancer, especially those of you here that are from Egypt. You know that probably a good amount of bladder cancer is not a transitional cell carcinoma, but it is a squamous cell carcinoma being derived from the squamous metaplasia that these schistosomes cause in the bladder. And finally, you may hear the term filariasis. I'm not going into this, but filarial worms are very small worms. They can clog up lymphatics and show tremendous lymphedema, especially classically in the lower extremities in the colon. So when you go through the pathology books and you see elephantiasis, which is usually, the most horrendous picture in the entire pathology book, they're always referring to somebody who's had their inguinal lymphatics obstructed by these little worms. They all have complex life cycles. Now, I think we could probably end here, but I want you to remember, we discussed this before. We said that Ascaris enters the intestine twice, once as an egg and once as something that's been more developed in the respiratory tract. The worms are round, the male is bigger than the female, and this is basically the life cycle. We also gave you the life cycle of cysticercosis, and we talked about this from the pork. I think one thing you should know is that the scolex looks like this. A classical board question is to show you a scolex, and if you see a scolex and it's very, very tiny little hooks right in the middle, like you see there, it's probably going to be pork. Of course, the scolex from the beef one is totally different. We've already went through this life cycle as well. But remember, not only is it a flatworm that lives in the intestine, it can also wreak havoc in the soft tissues, in the muscle, in the brain, just about any part of the body. Here's a brain that's been infected by little abscesses due to cysticercosis, which is, of course, tania, which is the pork tapeworm. Okay, I didn't. I know I breezed through that quickly, but we had that in greater detail before. I just thought it was important that you, if you really don't want to memorize all these life cycles, but you're afraid you're going to be asked a life cycle question, these are probably the areas, the two that you're going to be asked about, or you'll have to know something about. Okay, guess what? It's 10 o'clock. We can take our break. I'm going to make a big, nice announcement after the break. And during the break, we're going to be listening to songs from you. One of them is Dr. Devarajan again, and also another one from our Adil H., who submits a lot. Listen to 3 songs. See you in 10 minutes.
Hiding from the rain and snow, trying to forget, but I won't let go. Looking at a crowded street, listening to my own heartbeat. So many people all around the world. Tell me, where do I find someone like you, girl? Take me to your heart, take me to your soul. Give me your hand before I'm old. Show me what lovers haven't got a clue. Show me that wonders can't be true. They say nothing lasts forever. We're only here today. Lovers now or never. Bring me far away. Take me to your heart, take me to your soul. Give me your hand and hold me. Show me what love is. Be my guiding star. It's easy. Take me to your heart. Standing on a mountain high, looking at the moon through a clear blue sky. I should go and see some friends, but they don't really comprehend. Don't need too much talking without saying anything. All I need is someone who makes me wanna sing. Take me to your heart, take me to your soul. Give me your hand before I'm old. Show me what lovers haven't got a clue. Show me that wonders can be true. They say nothing lasts forever. We're only here today. Lovers now or never. Bring me far away. Take me to your heart, take me to your soul. Give me your hand and hold me. Show me what love is. Be my guiding star. It's easy. Take me to your heart. Take me to your heart. Take me to the soul. Give me your hand and hold me. Show me what love is. Be my guiding star. It's easy. Take me to your heart. soul. I feel nothing's like it used to be. Sometimes I wish I could turn back time. Impossible as it may seem, but I wish I could so bad, baby. Quit playing games with my heart, with my heart, my heart. I should have known from the start. My heart, my heart, my heart. I live my life the way to keep you coming back to me. Everything I do is for you. So what is it that you can't see? Sometimes I wish I could turn back time. Impossible as it may seem, but I wish I could so bad, baby. Quit playing games with my heart, with my heart, my heart. I should have known from the start. My heart, my heart. Quit playing games, baby. The love that we had was so strong. Don't leave me hanging here forever. Oh, baby. This is not right. Let's stop this tonight. Quit playing games. Na 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 na. Sometimes I wish I could turn back time. Impossible as it may seem, but I wish I could so bad, baby. Quit playing games with my heart, with my heart, my heart. I should have known from the start. My heart, my heart. Quit playing games with my heart. Quit playing games with my heart. My heart, my heart. I hear the ticking of the clock. I'm lying here, the mood switched off. I wonder where you are tonight. No answer on the telephone. And the night goes by so very slow. Oh, I hope that it won't end alone.
We're back. That was beautiful music. Thank you to our contributors. Um, I don't know if you realize this, but we are done with 8 chapters. We've gone through the introductory and lab material. We've gone through inflammation, adaptation, regeneration, hemodynamic, genetic, immune, neoplasm, and now infectious. Actually, those are the first 8 chapters of what we call general pathology. And even though there's a couple of more chapters called environmental and nutritional, these are not what you would call key understandings of pathology. These could just as easily have been thrown in with the systemic. So I feel very good about this. The reason why I'm saying this is because, oh, let's see, I guess this is my big announcement, I guess. You know, I'm talking today a little bit differently. It might sound like I have a cold, and it's because I do have a cold. I got a little stuffiness and sinusitis and boogers, so to speak. I usually get a little bit of a cold when the weather turns cold in Chicago. And the weather is starting to turn cold, you know. So I got my little cold. So what I usually do when I get a cold is go to a warmer place. So here's the big announcement. We will continue this course as promised throughout the entire year. That is one thing that will never change. But my body is going to be in a warm part of the world called Puerto Rico. At the beginning of the course, I mentioned that I often go as a visiting professor to places that are warm during Chicago's cold winter, and some of the students said, hey, well, why don't you talk to our people? So I talked to the deans over at a medical school in Puerto Rico called San Juan Bautista. It's in a town called Caguas. It's not far from the capital city of San Juan. And I'm going to be moving my body there during the cold weather. I'll be there for 3 months. Now, here's the good news. Usually when I broadcast to you on Tuesdays and Thursdays religiously, I'm here in my studio in Lake Bluff, okay? It's a nice room. I'm all by myself. There's a little bit of sunlight. And there's nobody else in the room except for my dog, okay? So the difference is going to be is that I'll still be broadcasting to you at approximately the same time and approximately the same frequency, but now I'll be in a room full of real warm-blooded medical students as well. I've done this before several times, and I've never quite been able to totally synchronize my course of online, which I'm devoted to the rest of my life, with a medical school course. I tried it last year in the Caribbean island of St. Kitts. It worked pretty well. There were some technical glitches, which I don't want to do again this year. So here's the news. We'll continue the course, but we're going to be continuing it with, rather than a single person in a cold, lonely room, we're going to be in a room with warm-blooded people on a warm island called Puerto Rico, and you'll have just as much of input and just as much experience as when I'm all here alone. Now, the couple little adjustments we have to make is that they have what they call a systemic curriculum. So that's why I said we're done with most of the general things. I think next week we'll be starting with kidney, or, rather than, it doesn't matter how you take the systemic pathology chapters. It doesn't matter if you start with red blood cell or GI or bone. We're going to start with kidney next week. Okay, now here's the little adjustment you have to make. It may not be at exactly the same time, and we're not going to be finishing the so-called general topics right now of environmental and childhood. We will eventually. But the good news is that I'll feel like I'm more effective if I have, like real medical students. I know you're all real medical students, but these are like warm bodies, and that makes me perform even better. So, except, when I'm in a classroom, that means I have to comb my hair. It means I have to, put on clothes, and I just can't get spoiled like I am over here. So, This is the bottom line. This is what it means to you. You will all be notified by email. I have all of your emails. You will be notified several days in advance of the times and the topics, as usual. I know a lot of you are in the habit of going to the Facebook pages we have, but you will be notified with the new changes. Now, I know a lot of you, I really appreciate the fact that you all take the time to come to these recording sessions here and interact with me. I love that very much. But it's going to be at a slightly different time, like rather than, for example, 9 o'clock Chicago time, it might be noon Puerto Rico time, which is like about 10 o'clock Chicago time. So it may be an hour or two off. And normally I do this every Tuesday and Thursday. We'll still be doing it about 2 or 3 times a week, but it may not be Tuesday and Thursday. It may be like maybe Monday and Thursday or something like that. So those are the adjustments that you have to make. And I want to tell you something. There's no doubt as to what is more important to me. My online course, my free course, is much more important to me than being paid by a profit-making medical school. That doesn't mean that I like free students better than paying students. It means that, like, I am, my calling, my vocation, my calling is to teach the world. And that's you. My calling is not necessarily to amass a lot of money in a profit-making private medical school. But I'll be able to do both. And if, for example, if I get to Puerto Rico and the dean says, oh, you can't do your online course with our students. This has been told to me by some of the other, I'm going to say, well, I enjoyed the weather here, goodbye. So I told the dean that I would only do this as if everything that comes out of my mouth in their auditorium is going all over the world. Okay, so thank you for the adjustment. You'll be all notified by email, and I could see some of your comments already. So right now, I want you to think, do you have any more specific questions? Did I explain it clearly? Wait to be contacted by email, and you may have to change your times or your days a little bit, but they will still be 2-hour sessions. Okay, I'm glad I made it clear, and I'll keep my promise, and this is going to be really, really fun. You know, it's really nice to have real students in front of you also. And by the way, another nice thing is they are allowing me to take my dog, so I could bring Woofy to Puerto Rico as well. I don't know if they'll let him into the classroom, but I'm going to try. If they kick him out, they kick him out. But I'm going to try to take my dog into the classroom too, because he does everything with me. Guess what? We have a lab now. We spent 5 hours talking about infectious diseases. I dragged out about 20 cases here. Usually in 1 hour, we never finish all 20. Usually we do about 10 or 12. So we may have to either go through some of these pretty quickly or perhaps decide which are the more important ones. And they're not in any particular order. They are basically, look like they're sort of the order in which I drag them out. And these are going to be histopathology of different aspects of infectious diseases. And as with all of our lab sessions, are you all sitting down nicely in your chair in front of your microscope right now? Because I'm going to be throwing out some slides for you. And you could probably guess what they are by the name, but please don't, let that bias you in some of your responses. Here, let's take a look. Most of these are pretty quick. This is the first microscopic slide that I'm going to put under my microscope. And now I'm looking at it. Everything is in focus. You don't have to adjust your eyepieces. And I think you pretty much quickly, hopefully knee-jerk. Do you know what organ this is? You know it's a GI organ because it has muscle here, it had connective tissue, maybe serosa on the outside. You can see glands on the inside. But you notice the majority of the thickness of this organ are lymphoid follicles. So you all know that this is what organ? Appendix, yeah, thank you. And normally when a pathologist looks at appendix, he right away goes into the smooth muscle and see if there's any neutrophils infiltrating the smooth muscle. And guess what? We could do this all day, but I'm going to do a little blow up here of the wall. And are there any neutrophils at all infiltrating these beautiful longitudinal, and here's some circular, here are the circular, here are the longitudinal smooth muscle fibers. So it's not appendicitis, is it? So you're thinking, well, this is a normal appendix. Why the hell did the surgeon take it out? Or maybe we should send that surgeon up before the tissue committee for taking out normal appendixes. But then you go, okay, well, here's the mucosa, here's the submucosa with the lymphoid tissue, here's the muscle, here's some hyperemia in the blood vessels in the serosa, but I don't think hyperemia of a serosa is going to cause much pain or a specific appendiceal symptom. Well, here's the lumen. The one thing you never, ever concentrate on is the lumen, because all that has is what we call caca, poop. Okay, nothing. You don't want to look at poop inside of the lumen of an appendix. But if you are thorough, you'll see that this doesn't look like anything we see. Now, that might be a little vegetable fiber there. But look at, here's something that has little bodies inside of it, and it looks like there's a little muscle in there, maybe the intestine of a worm. So this is pinworms, Enterobius vermicularis, in the appendix. It may or may not have caused a clinical symptom of pinworms. You know, it may be a kid, for example, and his only symptom might have been an itchy butt, for example. But I'm sure if I was a microbiologist, I could tell you the precise names of all of these structures inside the pinworm. That looks like an appendix to me. But the thing is, this does not look like human tissue of any type. So whenever you cut through something like this, think, and it doesn't look human, you know, think non-human. In this case, a worm. But look how nice the mucosa is. Look how beautiful these glands are. This is a normal appendix with a few pinworms on the inside. Not a rare thing for a pathologist to see. Can you guess what this next tissue is going to be? I know if I zoomed in real quick, you'd probably guess what kind of tissue it is. In fact, for those of you that are real neuro freaks, you could probably even tell me what part of the brain it is. But let's go to an area like this, and you can tell these are meninges here, possibly, or no, more likely probably ventricles, because they look like they have little papillary structures. This is probably part of a ventricle. You know, this is brain. If you see a part of brain that looks like there's a lot of cells, you know, it might be a nucleus, or it might be, you know, part of the brain that has a lot of cells. If it's generally a sort of a whitish part, it doesn't look like there's a lot of big cells or a lot of neurons, you think it's white matter. So what are the majority of the cells here? Glial cells or neurons? And for those of you who guessed hippocampus, you're right. That means you really got a good grade on your neuroanatomy. Okay, so these are neurons, and what are most of these nucleated structures on the right side? Glial cells or neurons. Yeah, glia. And what is the stuff between the glia? This is just myelinated cells. You see, a lot of these nucleated cells have little halos around them. Those are oligodendroglia, okay? So this is white matter. This is probably part of a nucleus. And by the way, what is this structure over here? It should be a slam dunk, quick, easy, knee-jerk recognition. What is this structure here? Oh, come on. Come on. Yeah, somebody said capillary or small blood vessel. Yeah, that's what it is. So let's say that this person died, you know, after a dog bite or a skunk bite, you know, with severe nervous system. Well, then you would probably go to the part of the brain that you thought might have been involved by his symptoms, or a part of the brain that has a lot of neurons, and you would be looking for what inside of the neurons. Did you ever hear of the word Negri body? Well, the diagnostic features of this infectious disease is, number one, it's a virus. So number two, it may cause also a viral encephalitis kind of picture. But the diagnostic feature of rabies, and we may not see it, okay? Because these are hard to find. And I know every year I look through these with the students and I go, oh yeah, I think this might be one. So what a Negri body is an eosinophilic inclusion inside of the neuron, but it's not in the nucleus, it's in the cytoplasm. So here, let me show you theoretically what a Negri body would be, and then I'll show you a real Negri body. So I'm going to zoom up the northeast over here. Here's a nucleus, but let's say outside of the nucleus, like maybe here, you see that little red sort of structure? You can't just agree with me. You got to say, Dr. Minarcik, I see an eosinophilic cytoplasmic inclusion in the neuron. And that's defined as a Negri body. And I could see, if you see it, just say yes. If you think I'm full of baloney, just say FOB. Okay, well, I don't see any FOBs yet, but, if I did, I know you're at least honest. Now, what I did, because I have a hard time finding these every year, is also captured one diagnostic field, which is perfect. Because if you go and Google the very, very best Negri body you could ever find, here it is. There's some glial cells surrounding this. It may be more of an inflammatory area. You have a perfectly nice neuron. You can see Nissl substance. And then you could see a red intracytoplasmic inclusion that's about as big, even bigger than the nucleolus. That's a Negri body. Oh, just offhand, if you're lucky enough to see some protrusions come out of this, what they call the soma or neuron body, if you see like a filamentous structure come out of it, but it's void of Nissl substance, is that an axon or a dendrite? I gotcha. It's an axon. Sometimes that's the only way you could tell. Yeah, axons are void of Nissl substance, but if something extends out of the so-called perikaryon and it still has that granular Nissl substance, it's probably a dendrite. Anyway, that doesn't pertain to this at all, does it? Okay, here's another case. We're moving right along here. And I think now that you have been keenly attuned many, many times to what central nervous system tissue looks like, let me just ask you quickly, is this a brain, yes or no? You don't have to know the names of the cells. You know these are mostly glial cells. Oh, maybe you could, that's a blood vessel. That's probably a blood vessel. They're mostly glia. The glia that have the little halos around them are oligos. This is probably white matter. I don't see too many neurons here, so maybe it was kind of a pure white matter. But let's say that you're looking at this brain, and it looks not too bad. Here's another nice bigger blood vessel. And this is in a person who died with a history of syphilis. Okay, now you see an area that's very gliotic. There's a lot of inflammatory cells around here. And look, these inflammatory cells are surrounding an area in which looks like it's necrotic. In other words, there's no nuclei and there's no structure. Now, offhand, some of the smarter of you might say, well, this could be a granuloma. And you know what? I wouldn't blame you if you did say that, because the gamma of tertiary syphilis can kind of be thought of as a large granuloma of syphilis, except they don't call it a granuloma for some reason. Now, even if, I don't know, I don't think we're going to find any multinucleated giant cells, but let's just call it a localized necrotic area surrounded by inflammatory cells, and that's the gamma of syphilis, and happens to be in the brain. And of course, gummas of the brain. In the old days, tertiary syphilis was very lethal. Let's see if we want to move around a little bit more. I doubt if we're going to see any multinucleated giant cells, but who knows, maybe we will. You think this might be one over here? Let's zoom it up. Then if you see a multinucleated giant cell, you're going to think, oh my God, maybe this is a granuloma. So if you want to call a gamma a big necrotic granuloma of syphilis, you could do it. But the name classically has always been gamma. And by the way, you see these inflammatory cells at the edge of the lesion? Are they mostly acute or chronic inflammatory cells? I just need the answer. They all look pretty round to me. Yeah. Oh, come on. Not too many of you are seeing neutrophils, right? A couple of you said acute, but I really don't see too many neutrophils here. Maybe that's one. Don't you agree they're chiefly round mononuclear cells? Okay, the vast majority is saying chronic. Okay, but the ones that said acute, you learned something, didn't you? The ones that said chronic didn't learn a damn thing. They just proved how smart they were. Here's another brain. And this is not an anatomic term we're going to use now to describe this brain. This is a clinical term. This is also advanced syphilis. Okay? This is a term called paresis. It referred to the fact that the brain being involved with extensive infection produces paralysis like structures as well. So look at this is a little part of a ventricle, isn't it? Maybe if we look closer and look at all these are blood vessels here, aren't they? And the rest of this is generally brain. And look, here's a meninges. The meninges look pretty good, except for one thing. Oh, I don't know. Let's take a vote. Do you want to say that these meninges are a little bit inflamed or not? Just yes or no. I don't care. I'll go whatever what you say. If you want to say yes, it's not very much. So this is not predominantly a meningoencephalitis. This is predominantly an encephalitis. Now let's go to the ventricles, because it looked like there was something funny inside those ventricles. Is the primary inflammatory focus in this brain in the meninges, or perhaps the blood vessels in the ventricle? Let's take the ventricle first. That's a lot of inflammation, isn't it? Yeah, I had a friend that used to talk about treponemes in the ventricles, you know, so the ventricular system is one area, but this is not just a localized lesion like a gamma. This is kind of like a diffuse encephalitis, isn't it? And here, let's look at another area, because it looked like some of these blood vessels were also surrounded by inflammatory cells. Oh yeah, that's an encephalitis. In fact, remember we said a classical encephalitis, especially the viral encephalitides, result in extensive lymphocytic cuffing of the blood vessels of the brain, the so-called Virchow-Robin space. You know this is an encephalitis. Okay, here's the final question. If you didn't know this was syphilis and you wanted to be honest and somebody said, is this primarily a meningitis or an encephalitis or a meningoencephalitis? What do you want to call it? Just say M-E or M-E. Yeah, you're almost all saying E's. There's a few of you that are saying M's because I think there were a few extra cells in the meninges. But the general rule is if a meningitis is severe enough to extend into the brain, it's called meningoencephalitis. If an encephalitis is severe enough to extend into the meninges, it's also called a meningoencephalitis. Okay, we're done. What about this one now? It seems like we're looking at a lot of brains today, aren't we? It's also a brain. Can you recognize this slam dunk right away as being a brain? Here, let me zoom it in for you in the Midwest here. Classical brain, a lot of blood vessels, mostly glial cells. Oh, I don't know, maybe we could find a couple of neurons, maybe some of these bigger cells, but it doesn't look like a terribly abnormal brain, does it? If it was terribly abnormal, you probably wouldn't recognize it as brain. Now, let's go to an interesting part of this brain, however. That looks pretty normal. I'm zooming out. Look, there's a blood vessel. I don't know, that blood vessel looks a little, let's take a look at that blood vessel. See, this is how pathologists think. They see something funny and then they zoom in on it. Well, blood vessel shouldn't be that prominent. So let's zoom in on this guy. Well, we have a blood vessel all right, but look at all of the lymphocytes cuffing it in the theoretical Virchow-Robin space. And if you believe that it is, and it is, then you might say, well, maybe there's a little bit of extra glial cells in this brain as well. Maybe there's a glial reaction, just like there's a lymphocytic cuffing in the vessel. So, you want to see something cool? Let's go to another vessel. Now that you know that that guy is funny, I bet you if you looked at this guy or this guy or this guy, they'd probably have a lot of lymphocytes surrounding the blood vessels too. Oh my God, look at that one. Okay, it's showtime. You have to tell me what's your diagnosis. Just type it in, and by now you'll probably all get it right. Yeah, you're all saying encephalitis. And some of you are even saying viral. Now, can I ask you a question? Are most of the encephalitides of the brain viral or bacterial? Okay, you got that right. Now, here's the trick question. Are most of the meningitis viral or bacterial? Yeah, isn't that interesting? Most of the meningitis are bacterial, most of the encephalitis is viral, and this is a classical viral encephalitis. Now, if you say, well, is this arthropod-borne virus, is this West Nile, is this Venezuela, or you don't know. What it is the honest description of classical encephalitis. Let's move on. We're making good time here. This one's going to be the easiest of all. In fact, I'm going to not even say anything about this. I just want you to give me a diagnosis. Right away. Come on. And yes, it's coming through. You're coming through with the right answer. You're all saying, I have a long string of meningitis. Good. So here's the next question. Is it primarily a meningitis or is it a meningoencephalitis? It's primarily a meningitis, isn't it? Okay, next question. If this was a kid under the age of 2, what would be the most likely bacteria causing this? Haemophilus, correct. If this was seen in an epidemic setting where a lot of people are getting it, what's the most likely bug? Neisseria. You got that one right too. And there's a bunch of other bacteria. You know, technically any bacteria. You know, you could have E. coli causing this. You could have a whole bunch. You could have fungals. If this was a person that was on extensive chemotherapy and was greatly immunosuppressed, what you think it might be? Maybe Cryptococcus? Yeah, okay, good. You got the general idea. Let's move on. Let's go to the next one. And let's see, I think, what is the organ here? I don't think it's brain. It looks too cellular to be brain. Can I ask you a question? What's the organ? Look at, here's a bile duct, here's a portal vein. This looks like another bile triad. There's another triad. So you know this is liver. But what's the funny thing about this liver is that you got little clusters of white things disrupting the normal lobular architecture. So right away, you're going to say, to hell with these normal portal areas. I want to look at some of these little white things, which to me glaringly interrupt the normal hexagonal or normal portal architecture of the liver. I don't care which one you take. Let's take the one in the middle. Oh, you can see hepatocytes. Ooh, look at this. What are these little round balls and clusters? They look like they're yeast to me. And furthermore, do you see how a lot of them look like they have a big white capsule as part of their structure? Look at, they're sort of like the nucleus. Let's say that this also was a patient that had central nervous system findings, and you put a drop of their spinal fluid on a slide. What's the next drop you want to put on after you put on the spinal fluid? The India ink, you're right. So this is probably Cryptococcus neoformans. Now there's other species of Cryptococcus, and some of them I can barely pronounce, but by far the most common cause of cryptococcal systemic infections is Cryptococcus neoformans. And once again, this shows that you just cannot think of it as involving meninges or central nervous system. This patient probably did have central nervous system involvement, but we could see it here disrupting these cords of liver cells as well. Okay, final question. What are 80% of the cells that you see in this field that have perfectly round nuclei? Right, hepatocytes. Now, what's the relatively smaller percentage of cells like you see here that look like they're a little fusiform, or maybe here? Those are probably the Kupffer cells, right, of the macrophage line. And what are about 90% of the cells within the circle here? These are the actual little yeasts, aren't they? So Cryptococcus is primarily a yeast. Okay, we're done. That was a nice case. And it's been consistent with everything we've been saying. Let's take another slide of infectious disease. And I think you're going to recognize this looks like some kind of maybe GI organ, because you can see a lot of muscles going in various ways, and maybe this is a GI organ also. The one thing that you do notice, however, is that even though you can maybe recognize some connective tissue, whether it's a serosa or an adventitia, you can see a lot of muscle. You can also see some inflammatory changes. But the one thing that is glaringly funny about this slide is that you don't really see mucosa. You don't see glandular mucosal cells. Agreed? So what are you seeing instead? I'm going to zoom in this part where you should be seeing mucosa. Now I want to ask you, what do you see here? Do you see yeasts? Do you see hyphae? Or do you see both? When you see an extensive fungal infection, or when you see an extensive infection, and it's both these stringy-like hyphae as well as a lot of these little balls staining the same way because it's the same substance, it's Candida until proven otherwise. Okay, now there's a lot of other exotic fungi that can do this, but 9 times out of 10 it's Candida. And look at it, they look growing like little bushes, aren't they? And I don't know, one of these is supposed to be an esophagus and one of them is supposed to be a colon. And to tell you the truth, because there's no mucosa, it's going to be hard for me to figure out which is which. I think, I don't know, does anybody want to take a stab at it? Which one is esophagus and which one is colon? I guess if I thought it out, we could figure this out, but I really can't tell. If somebody knows for sure, just give me the answer, because I'm at a loss here. The mucosa is wiped out. Here, I'll take the one on the top, and look. I bet you these are all little Candida as well. Oh, yeah. See those red hyphae? See those little balls? Okay, final question. Do you see that little... Oh, no, let me find a better one. Do you see... Let's call this thing here. See the little thing at the tip of the arrow, and it looks like it's a yeast? Let's say that it has a little bud on it. What is that little bud going to grow into? Hyphae. Thank you. Got the idea. Let's move on. Let's go to... now this I think you'll recognize as colon right away. Excuse me. Because you can see some colonic glands here. You could see, circular and longitudinal. You can see fat on the outside. You could also see that a lot of the mucosa is ulcerated. and the submucosa and mucosa is largely inflamed. So this is an inflammatory bowel disease, isn't it? And it's resulting in ulceration. And you might be tempted to call this ulcerative colitis because it doesn't involve the wall too much. But I got to be honest with you. I'm going to show you something that I know you're not going to believe, but I got to show you anyway. Oh, let's look around over here. There's inflammatory cells. There's fibrin. Here's some necrotic debris. Could that be part of feces or just inflamed debris? What they call detritus. Whenever you see granular junk, pathologists often call that detritus. I'm going to show you something else. You see this blood vessel over here? I'm going to zoom it in a little bit. And I'm going to give you a very, very, very unfair question right now. This is in an inflamed area. You can see it's not too far from the mucosa. Can I ask you something? What is this little thing here? Right here. Does it look like just some foamy macrophage with junk in it? Or here, look at this guy over here. What is this little thing here? It looks like it has a small nucleus. I know you're all going to get the wrong answer, so I might as well tell you what it is. It's an amoeba. So, in all honesty, you might thought that was an unfair question, but if I showed this slide to my top 10 pathologist smart heroes, they'd probably miss it all too. And then when you say, oh, by the way, this thing was absolutely identified with special techniques as being antigens of an amoeba, then they'll say something like, oh yeah, I knew it was all the time. But here, actually these were pointed out very nicely in Rock Lab, so I'm going to show you the picture that I took because I put the arrows on it. You see the three arrows? That one there, and that one there. They're all pointing to amoebas. And for all practical purposes, most people can't tell the difference between an amoeba and maybe like a macrophage with a lot of junk in it. So here's the only question I want to ask you. Would most cases of amoebic dysentery be completely missed even by experienced, smart pathologists? Yes or no? Yeah, you got that one right. It certainly would have been missed by me. Oh, here's the second part of the question. If you told a pathologist that those were confirmed by fluorescent studies as being amoeba, would they all say, oh yeah, I knew that? That's the way people are, aren't we? Here's another infectious disease case. And you can see it's a stratified squamous mucosa. There's ulcerations and inflammation. And, oh, I don't know. I guess this could be an esophagus. Actually, it is. And if I showed you, oh, some maybe esophageal glands, which there aren't, and maybe you'd believe me more. Other than that, all you can know is it's not skin, and it's a non-keratinized stratified squamous mucosa. It has a thick wall. I guess it could be a vagina. But this is an esophagus. There's probably some skeletal muscle out here if you look at if it's the upper part of the esophagus. But there's ulceration and inflammation. Okay, let's see if we can really nail this down. Well, look at some of these squamous cells look like they're a little bit bigger and darker. And look at, especially in the area of ulceration. These look normal over here, but let's move around a little bit. This is something I've had a hard time finding also. Oh, I think I could find something for you if I look hard enough again. Oh, and I hope I could find it this time. Because sometimes you have to look at a long time for these, and then when you find one, sure one, you go, oh yeah, I can see more. Here, let's take a look at this cell here. I'm going to have to stretch your imagination a little bit, but is that a eosinophilic intranuclear inclusion? Yeah, somebody said coilocytosis. So you're thinking virus, right? But this is not HPV. This is an inflamed esophagus with a eosinophilic intranuclear inclusion. HSV, you got it right. Remember all of the common viral families in the herpes family have intranuclear inclusions if you look hard enough. If it's basophilic, it's CMV. If it's eosinophilic, it's either herpes simplex or herpes zoster. And of course, in an esophagus, it's not going to be herpes zoster. So this is a herpes simplex esophagitis. And I know what you're thinking. Well, where are the vesicles? Well, the vesicles are gone, okay? In most cases of herpes, the vesicles are gone because they've been irritated. You know, they might be secondarily infected with bacteria even. So this is a HSV esophagitis. Let's move on. Oh, I'm going to ask you the question now. Are we going through these slides too fast or too slow? Or just right? Because I don't like to spend a lot of time, you know, looking at it. Okay, I'm glad most of you are happy. What about, oh, let's skip this one because I know we don't have a lot of time. Let's take this guy. I think you'll recognize the organ right away. Here's the question. What is the organ? You got to tell me. If you don't know this right away, I'm going to flunk you. I might blow it up a little bit because you know your grade is on the line here. Here, what is this? What organ? Yeah, you all know it. So let's. The thing that's really glaring about this kidney here is that it looks not too bad, but then there's an area down here. So, you know, if you're even not a pathologist, if you're a 3-year-old kid and somebody says, "Oh, what's the funny area?" You're going to say, "This is." So let's zoom it in. Okay, so it's a localized area of inflammatory cells in the kidney. Let's see if these things are neutrophils, in other words, acutes, or mononucleated cells, or chronic. Are these polys or monos? P or M? Acute or chronic? Some of you are saying monos. No, these are polys. Take a look. Look at that's a lobulated nucleus. That's a lobulated nucleus. That's a lobulated nucleus. They're just kind of necrotic looking. These are polys, and you actually, if they were monos, if they were lymphocytes, they wouldn't have nearly this much cytoplasm either. So what do you call a localized collection of polys anywhere in the body, not just the kidney? Okay, an abscess. And because it's a kidney, and you have an abscess, it could technically be anything causing an abscess. But in the area of a kidney, do you think these are most likely, if we did a really good gram stain, to be gram positive or gram negative? Most of your kidney infections are caused by the so-called gram negative ascending bacteria. In other words, E. coli, Klebsiella, Pseudomonas, Aerobacter, blah, 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 blah. What they call the ascending infections, most pyelonephritis, most renal abscesses. Okay, final question before we move on. I'm going to ask you one thing. You got to be totally honest. I know you always are. And I want to ask you, are these glomeruli perfectly normal? Yes or no? Oh, I don't know why you're saying no. They look, well, are you saying they look a little hyperemic? Yeah, I agree, they're a little hyperemic because there's a big inflammatory process nearby, so they're not perfectly normal. But they don't have any cellular infiltrates or anything like that. These are pretty normal glomeruli. I could see why you all were saying no. Were you saying no because they looked like they were hyperemic? Okay, good. Now I will forgive you. Let's go on to the next case. We're going to show you a very important lesson on this one about infectious diseases in general. Here's a slide, and I bet you that you will, if you were in Histology 101 and somebody showed you this, what would you call it? Would you call it skeletal muscle? Would you call it fibroblast? Would you call it cardiac muscle? Would you call it smooth muscle? Would you call it bone? So I already know this is the heart. And in all honesty, would you say that those myocytes or cardiac muscle cells look pretty normal? Yes or no? They look pretty normal to me. It's striated. It's striated. But if I was to say, and is this a coronary artery here running in the epicardial fat? And look here's part of a coronary artery here that is so big you should probably know the name of it. You don't even see the whole thing there. But we don't know where this is from, so we don't have to get fancy. Okay, here's the question. Is the primary focus of inflammatory, or let's say infection, myocardial or pericardial? Yeah, this is all pericardium down here, isn't it? And it looks like there's a lot of inflammatory cells, doesn't it? And now I'm going to teach you a very important lesson. I'm going to take this area here, and you can see these are all inflammatory cells. By the way, are they neutrophils or are they lymphocytes? I'll blow them up for you bigger if you want. Is this polys or monos? Yeah, you all got it right this time. And what's the red stuff in between them, most likely? Probably fibrin, right? It looks pretty red to me. So let's go back down, and I want to ask you no, I don't want to ask you something. I want to tell you something. Remember yesterday when we saw the calcification that was associated with acute inflammation? I said, well, if acute inflammation turns into chronic inflammation and then there's a lot of fibrosis, often you see calcium. And calcium is kind of crunchy and very, very bluish black and granular. And I said, there's nothing else in the body that looks like calcium except for large clusters of bacteria. So if this was a heart valve, an endocarditis, a bacterial endocarditis, you might see these large clusters of bacteria that look like calcium. Folks, these are primarily bacteria. And remember, even though we would prefer a gram stain, the gram-positive bacteria, not only do they stain blue because of the crystal violet, but they also stain blue with hematoxylin as well. And if this was a real microscope with oil immersion rather than a digital microscope, you would probably be seeing at the lighter edge of some of these things individual coxal bacteria. And the reason why I say cocci is because if it's gram-positive, you're much more likely to see cocci than bacilli. So this is a bacterial acute endocarditis. Okay, guess what? We've already gone over the time limit, and I've showed you most of the slides. We never get to all of them. I could show you a few more spectacular cases, but consider yourself finished and graduated from the chapter and infectious diseases. I know it wasn't enough. But I just cannot give an entire micro course. Okay, folks, I guess we'll call it a day then. And remember, in terms of the announcement, I will notify you by email when the next session will be, all of you. And by the way, it might not be next Tuesday. It might be a week from today, depending on my travel plans, because I'm supposed to travel on Monday, so I don't know if I'll be able to do this on Tuesday. But no matter what happens, the main message is check your emails for messages. Thank you very much for coming with me to the recording sessions. And now I'm going to have real bodies at the recording session too. Maybe not Shakira, but real medical student bodies. The closing song will be something we played before. And it was such a beautiful song. I'll tell you, I could probably play this, every session. I just love it so much. Don't be surprised if I play it a lot more. It's a song that was given to us once again by Dr. Devarajan. And I don't know, but I just love this song. We will see you in about a week, maybe earlier. Check your email.
If I had to live my life without you near me, the days would all be empty. The nights would seem so long. With you I see forever oh so clearly. I might have been in love before, but I never felt this strong. Our dreams are young and we both know they'll take us where we want to go. Hold me now, touch me now. I don't want to live without you. Nothing's gonna change my love for you. You wanna know how much I love you. One thing you can be sure of, I'll never ask for more than your love. Nothing's gonna change my love for you. You wanna know how much I love you. You wanna change my whole life, you, but nothing's gonna change my love for you. If the road ahead is not so easy, our love will lead a way for us, like the guiding star. I'll be there for you if you should need me. You don't have to change a thing. I love you just the way you are. So come with me and share the view. I'll help you see forever too. Hold me now, touch me now. I don't want to live without you. Nothing's gonna change my love for you. You wanna know how much I love you. One thing you can be sure of, I'll never ask for more than your love. Nothing's gonna change my love for you. You wanna know how much I love you. You wanna change my whole life too, but nothing's gonna change my love for you. Change my love for you. You wanna know how much I love you. One thing you can be sure of, I'll never ask for more than your love. Nothing's gonna change my love for you.
You wanna know by now how much I love you. One thing you can be sure of, I'll never ask for more than your love. Nothing's gonna change my love for you. You wanna know by now how much I love you. One thing all life through, but nothing's gonna change my love for you.
You wanna know how much I love you. One thing you can be sure of, I'll never ask for more than your love.
Rock on, you buzzards.